Hi everyone. Before we dive into today's topic, a quick note. If you'd like a private, one-on-one consultation, just click the link in the description to join my Telegram at My Private Doctor. I'm here to answer your questions and guide you through your health journey. See you there. Welcome back to the channel. Today, we're exploring gout and pseudogout, two crystal-induced arthritides that often present in similar ways but require different approaches. Pathophysiology gout and pseudogout predominantly affect middle-aged men and elderly adults. In women, gout usually appears after menopause. In fact, gout is the most common inflammatory joint disease in men over 40. It's important to remember that finding crystals in a joint doesn't rule out septic arthritis. Always keep infection in mind. Common triggers for an attack include trauma or surgery, certain medications such as allopurinol, diuretics, and aspirin, along with alcohol use, high meat or seafood intake, dehydration, and even cooler temperatures in the extremities. Clinical features: gout typically strikes suddenly, with rapid-onset joint pain developing over hours. The first metatarsophalangeal joint, what we call podagra, is the classic site, but the knee or ankle can also be involved. In chronic gout, tophi may form, causing asymmetrical joint swelling and yellow-white deposits you can sometimes see or even feel under the skin. Differential diagnosis: when you see monoarticular arthritis, think broadly: osteoarthritis, avascular necrosis, crystal-induced arthritis, gout or pseudogout, septic arthritis, reactive arthritis, trauma, malignancy, seronegative spondyloarthropathies, rheumatoid arthritis, systemic lupus erythematosus, and periarticular conditions like cellulitis, bursitis, or tendinitis. If multiple joints are involved, the list expands to include polyarticular mimics of the above. Evaluation: let's compare findings for gout versus pseudogout. Synovial fluid, aspirate gout, needle-shaped monosodium urate crystals that are negatively birefringent under polarized light. Pseudogout, rhomboid-shaped calcium pyrophosphate crystals with positive birefringence. Serum uric acid gout, often elevated, although about 30% of patients have normal levels during an acute attack. Pseudogout, uric acid isn't typically elevated. X-ray gout, not diagnostic. Pseudogout may reveal chondrocalcinosis, which are calcium deposits in the cartilage. Synovial fluid, white blood cell count. Both conditions show an inflammatory picture, usually between 2,000 and 50,000 WBCs per microliter. Gram stain and culture, both gout and pseudogout fluids, are negative unless there's a coexisting infection. Management: acute treatment, ED and outpatient. For all patients experiencing an acute flare, hold diuretics. Advise on alcohol reduction and dietary changes. If already on urate-lowering therapy, continue it, but do not initiate it during the acute attack. NSAIDs, first line, if no contraindications: indomethacin 50 mg orally 3 times a day for 3 to 5 days, naproxen 500 mg orally twice a day for 3 to 7 days, ibuprofen 800 mg orally 3 times a day for 3 to 5 days. Avoid NSAIDs in renal insufficiency. Consider opioids for pain control if needed. Colchicine use if NSAIDs are contraindicated and renal and hepatic function are adequate. Loading dose of 1.2 mg PO, then 0.6 mg an hour later for a maximum of 3 doses. Wait at least 3 days before retreatment. Adjust dose when patients take CYP3A4 inhibitors. Never administer intravenously. Steroids: prednisone 30 to 50 mg PO daily, then taper gradually over 10 days. Intra-articular injections can be used cautiously if infection has been excluded. Other options: anakinra An IL-1 receptor antagonist may be reserved for refractory cases but is not routine in the emergency department. Disposition. Most patients can be managed as outpatients unless they have severe pain, an uncertain diagnosis, or complications that warrant admission. And that wraps up our deep dive into gout and pseudogout. If you found this helpful, give it a thumbs up and subscribe for more medical insights. Remember, for private consultations, click the link in the description to reach me on Telegram at My Private Doctor. Thanks for watching, and I'll see you in the next video.